A good day to everyone. I am Dr. Ami Kunanan from the Philippine Pediatric Society Committee on Scientific Meetings. And welcome to the September online scientific activity. Let us all sing together the PPS hymn. To welcome everyone for today's activity, let us give a warm of applause to the President of the Philippine Pediatric Society, Dr. Jocelyn Eusebio.
Good day to you, my dear colleagues. We continue with our professional development activities organized by the PPS Committees on Scientific Meetings, CPD Online, and Child Health Informatics in cooperation with the Philippine Society of Pediatric Hematology. Inherited hemolytic anemia in children is not really rare among Filipinos. Improved diagnostic technology has allowed early and accurate detection of these disorders, paving the way for better proactive and preventive care. Likewise, the disease awareness created by this vigorous documentation of cases has allowed better understanding of its underlying etiology, epidemiology, pathology, and treatment. Today, the PPS joins the Philippine Society of Pediatric Hematology in unlocking two of these inherited hemolytic conditions, G6PD and thalassemia, zeroing in on what we need and must know. Allow me to thank the Psph, represented by its president, Dr. Minerva Ramos, and our proficient speakers, Drs. Domilin Arca and Edwin Rodriguez, for this collaboration as we protect, promote, and preserve the best interests of the Filipino child. On another note, I would like to remind all of you of our forthcoming first ever PPS Virtual Annual Convention on November 23 to 25, 2020. Please watch out for further announcement on the details. I now enjoin everyone to listen to our distinguished speakers. May we all enjoy the learning, and may God continue to bless all of us and the PPS with his never-ending love and mercy. Thank you.
Thank you very much, Dr. Eusebio. Today, we are fortunate to have with us the Philippine Society of Pediatric Hematology. To give us an overview of today's topic, to introduce our experts, and to moderate for this session, let us hear from the President herself, Dr. Minerva Ramos.
Good afternoon, colleagues. On behalf of the Philippine Society of Pediatric Hematology, and in collaboration with the Committee on Scientific Meetings, Committee on CPD Online, Child Health Informatics Committee of the Philippine Pediatric Society, we welcome you for this afternoon session on inherited hemolytic anemia in children, perspective and practices. Our first speaker, Dr. Domelin Arca, will expound on the current perspectives in glucose 6-phosphate deficiency, dehydrogenase deficiency among children. Dr. Arca received her medical training in the University of the Philippines College of Medicine. She also finished her residency training as well as her fellowship in hematology and oncology in the same institution. She has co-authored and published a book and presented her researches in both the local and international conferences. She is a diplomate of the Philippine Society of Pediatric Hematology, Philippine Society of Pediatric Hematologists, and a fellow of the Philippine Pediatric Society. Currently, she is a faculty member of the Janelta Foundation School of Medicine and an active consultant of the Perpetual Health Medical Center Las Piñas, where she is the current training officer of the Department of Pediatrics. To give us further insights into the current perspective in glucose 6-phosphate dehydrogenase deficiency in children, let us welcome Dr. Domelin Arca, pediatrician, pediatric hematologist, oncologist.
Thank you, Dr. Ramos, for the kind introduction. Thank you, PPS, for having me here today. And to our participants, thank you for tuning in. So for this part of the webinar, we're going to take a look at the current perspectives in G6PD deficiency among children and the management of the complication arising from this condition. We'll also take a short peek of some of the more common complaints that prompts referral of these patients with this deficiency to our subspecialty. But first, let us take a look on what is G6PD deficiency. It actually stands for glucose 6-phosphate dehydrogenase deficiency, which is an enzyme defect. Worldwide, it has a very high overall prevalence, and it is said to affect around 500 million people. That is worldwide, no? And here you can see the geographic distribution of G6PD deficiency, which is rather extraordinary. As you can see, it has a high prevalence in the tropical and subtropical parts of the world where malaria is also rampant. G6PD is prevalent in all 5 continents but is not reported in Amerindians, and the hypothesis is that because they have only been exposed to malaria in the past 3 centuries. And here you can see in this map, the shaded area would be the frequency of G6PD per country, and the red and the colorful dots would represent the polymorphic G6PD variants. And locally, according to the Philippine newborn screening data, in the Philippines, 1 out of 61 screened newborns have positive result for G6PD deficiency. Now, your patients or the parents of your patients may ask the following, no? Usually, they would ask, Doc, saan ba ito nakukuha? Doc, namamana po ba ito? But I think the hardest question that they would ask is, ako ba ang may kasalanan? Because some families or some parents could not accept that there is something wrong with their child, or their child is sick or afflicted, or sometimes it is the lolo or the lola that cannot accept that their apo has an illness, no? So, and they tend to blame themselves. So what do we do? Personally, I would tell them, well, this is something unexpected, something that nobody wanted, so do not blame yourself. And we can also tell them that there is a proof that this could be a result of a mutation. And to date, there is already 186 known human glucose 6-phosphate dehydrogenase mutation. And in this table, you can see the different mutations that could have happened. And among these 186 mutations, it is the missense point mutation that is more prevalent. So G6PD deficiency is also known to be X-linked disorder, and it is also associated with random inactivation of the X chromosome. And so this disease entity can be found in both males and female, but being an X-linked disorder, it is more commonly found among males more than the females. So how do we inherit G6PD deficiency? So first, let us take a look at, so this one, no, the X would represent the normal chromosome, and the X that is in the parenthesis would be the mutant chromosome, like this one, that as you see here. No? So given a situation wherein the father is a healthy person, and the mother is a carrier for the G6PD deficiency, as exemplified by the chromosome X and the X that is in the parentheses, as you see here. No? So in every pregnancy, no, there will be a chance that they would have the 25% chance that the child that the mother is bearing would be a carrier, as shown in this first box. Or there's also a 25% chance that the daughter would be normal and the son would be normal, which is also 25% chance. And there's also a 25% probability, no, that they would have a son which will have the enzyme deficiency. Okay, in a scenario wherein the father is the one that has the enzyme deficiency and the mother is healthy, there is a 50% chance that they would have a daughter that is a carrier, and also a 50% chance that their son would be normal. Okay, in the event that the father is the one that is deficient, meaning the father has a G6PD deficiency, as exemplified here, and the mother is a carrier, as you can see, only one of the X chromosome is affected, then there is a probability, a 25% chance that they would have a daughter that has the deficiency. And they would also have a probability, a 25% chance that their son would also have the deficiency. And in every pregnancy, there is a 25% chance that a daughter could be a carrier, and a 25% chance that a son would be normal. Now, in the fourth scenario, wherein the father is healthy, but it is the mother that is deficient in the enzyme, so in which case both the X chromosomes are affected, as you can see here, then in every pregnancy, there is a chance that their son will have the chromosome for the G6PD deficiency, and a 50% chance that a daughter will be a carrier. Now, in the last scenario, wherein both the parents, both father and mother, are deficient of the enzyme, so in every pregnancy, the chance is that if they had a daughter, she will have the deficiency, because both the mother's X chromosome are afflicted and the father's X chromosome is also affected. So she will inherit definitely the chromosome that has the deficiency. And there is also a 50% chance that if they had a son, their son would have the G6PD deficiency as well. Okay. So what happens in G6PD? Okay, so G6PD is a very important enzyme. That's why it's also tagged as a housekeeping enzyme. No? So if you recall, you still recall your biochem, no, from med school, you will remember that G6PD is important, no, because it is needed in the first step in the hexose monophosphate pathway, otherwise also called as the pentose phosphate pathway that you see here. Okay. So in here, this pathway is very important because it would provide the reduced form of the NADPH, which is actually the nicotinamide adenine dinucleotide phosphate. This is the reduced form. And this reduced form of the NADPH would provide the electrons needed to maintain the glutathione in the reduced form. No? So when the glutathione is in its reduced form, it would serve as an antioxidant that would protect the cells against oxidative damage. So therefore, if there is a deficiency of the G6PD enzyme, it would cause oxidant damage to the red cell, and eventually this could result in hemolysis. Okay, so how does G6PD manifest? Okay, so the following will be the clinical manifestations of G6PD deficiency. The classic manifestation of G6PD deficiency is acute hemolytic anemia. However, another syndrome of great clinical and public health importance is neonatal jaundice that is also associated with this deficiency. Another form would be the congenital non-spherocytic hemolytic anemia, which is a rarer form of this clinical manifestation, and it is a lifelong hemolytic process. For the neonatal jaundice in G6PD deficiency, let's take a look at its prevalence. The prevalence of this neonatal hyperbilirubinemia is twice as that of the general population. However, this rarely occurs in those who are heterozygous individuals or those who are carriers for the G6PD deficiency. And the mechanism involved in the neonatal jaundice in G6PD deficiency is not really clearly understood yet. However, it is associated with impairment of conjugation and clearance by the liver that leads to indirect hyperbilirubinemia. So when do we suspect neonatal jaundice in a G6PD patient, G6PD deficient patient? So neonates would usually present with hyperbilirubinemia within the first 24 hours of life. And when you interview the parents or the family, you would usually elicit a history of jaundice in a sibling. And you can also suspect this condition when you see that the bilirubin levels are beyond 95th percentile. And of course, this is predominant among Asian males. So what are the complications associated with the neonatal jaundice among patients with G6PD deficiency? So there is, of course, a high risk of hyperbilirubinemia. There is an earlier onset of hyperbilirubinemia, and there's an increased rate of kernicterus and even death in some populations, but not all. And how do we treat? So for severe conditions of neonates having jaundice and associated with G6PD deficiency, these patients may require phototherapy, and those who are really severe may require exchange transfusion. Okay, so for the congenital non-spherocytic hemolytic anemia in G6PD deficiency, so which is another form of clinical manifestation of G6PD, this is quite rare, and it is associated and said to be due to a sporadic gene mutation. Okay, and this condition is actually associated with chronic hemolysis. Okay, and sometimes the hemolysis can even occur during normal erythrocyte metabolism or in steady state, So you cannot really predict when they will have hemolysis. And the severity of the hemolysis varies. It can be in a form of a mild hemolysis, but it can also be in a form that is the patient becomes transfusion dependent already. And of course, just like any other manifestations of G6PD deficiency in congenital non-spherocytic hemolytic anemia, the hemolysis is triggered by exposure to oxidative stress. Now, let's go take a look at acute hemolytic anemia in G6PD deficiency, which is actually one of the more common reasons why these patients are being referred to us. Okay, so as I have mentioned earlier, acute hemolytic anemia in these patients would be the classic manifestation, no, of G6PD deficiency. To discuss acute hemolytic anemia in G6PD patients, I would like to share with you a case. No? So let me read it first. So an 18-year-old boy had a fever and cough and colds 3 days prior to consult. The cough was noted to progress and the patient was noted to be irritable, and he was noted to have beginning pallor and increased abdominal girth despite poor feeding. And in the history also, you ask the parents, and this baby was positive for G6PD deficiency. Okay, so then, given that case or that case scenario, no, when do we suspect that our patient is having a hemolytic anemia? Okay, so these are some clues, no? So I know you read about this during med school and also during residency, no? So let's try to remember the triad of hemolytic anemia. So first, your patient may present with pallor or anemia. Then, they can also present with jaundice, as well as splenomegaly. But in some patients, especially those with severe hemolysis, they can also have hepatomegaly, but the more common would be splenomegaly over the hepatomegaly. So again, the triad of hemolytic anemia, as we've seen in the previous case presented, no, the patient would have pallor or anemia, jaundice, and splenomegaly. So if you have this in your patient, then it should rouse in you the suspicion that, my patient might be having an acute hemolytic process or acute hemolytic anemia. Okay, so for that case that I presented, no, the patient was assessed to have G6PD deficiency in acute hemolytic crisis. Okay. So some would ask, are G6PD deficient patients toxic all the time? So my answer to you is no. They're not toxic all the time. Okay. In fact, there are instances when there are just like any normal kid, no? But then let's go ask, what makes them toxic? Like in the case, the patient that was referred to me was, he looks really toxic. Okay. So what makes them toxic is exposure. Exposure to what? Exposure to those materials or things that are contraindicated to them. One example, which is very much documented, no, is ingestion of faba beans. Another would be infection and exposure to certain oxidative agents. But there are also some reports, no, that trauma can also lead to hemolytic anemia among G6PD deficient patients. Okay, and some I've tried to read articles, no, and journals, no, most of them would say that infection could be the more common cause of acute hemolysis in G6PD deficient persons. And in the Philippines, actually, infection is number one, followed by intake of medications that are contraindicated. Not much of the food, because we don't have faba beans here unless, of course, you buy from imported goods. So we must check the label, no, because there might be faba beans there. Okay. But mostly it would be due to infections and due to intake of drugs or medications. Okay. So fabism. So there are areas, no, that have high incidence of faba intake, faba beans intake, no, so they call it fabism. And this is what they noticed, no, a few hours post ingestion of the faba beans, they would note that the patient, the child, would be already irritable and lethargic. And then at 6 to 24 hours, they will note discolored urine. And some parents would report it as brown, red, or sometimes they describe it as even black urine. No? And then during this time also, the patient can present with jaundice, pallor, and tachycardia. And at the 24 to 48 hours after intake, no, of faba beans, you will note moderate grade fever. Patient would also complain of nausea, abdominal pain, diarrhea, and less commonly, they could also present with vomiting. And during this time, patient may also show splenomegaly and hepatomegaly. Okay, so I got this list, no, from the newborn screening.ph that is very accessible. No, you can access it for free. You just type in your browser newborn screening.ph, then you will be able to view the different diseases that are included in the newborn screening, and some fact sheets and guide for doctors. So you can actually download it and print it. No? So in there, you'll see in this slide, no, you'll see some food and drinks that are recommended to be avoided now by patients who are G6PD deficient. And of course, number one is our faba beans. No? Okay. So again, some food that we can buy in the market already have faba beans. So please be careful, no, when buying from the imported items area. So check the label, especially if you have kids at home who are G6PD deficient. So check the label, make sure that there's no faba beans included. Okay. Aside from food, there are also a list of drugs that are contraindicated among these patients. No? So the first two drugs actually that were investigated long time ago, no, was dapsone and primaquine, no, and they are still contraindicated up to now. Okay. Here is another list. No, this one is from the newborn screening.ph again. So you'll see here a whole list of the drugs that are contraindicated among G6PD patients, and some chemicals, no, that are contraindicated as well. It's so hard to memorize them. There are a lot, no? But what you can do is print out a copy, have it with you in the clinic, or for the parents, no? Have it with you as a reference, as a quick reference. So every time you visit the doctor, you can refer to it and see if the drugs or the meds that's being given to you is contraindicated or not. And these are others, no, at iba pa, it says, no, the menthol. So before, no, it is you will see rampant use of efficacent oil being applied on the babies, no, para daw walang kabag, o hindi lamigin, no. But that's okay if the baby has no G6PD deficiency, no, but let's not advocate for that anymore, no? Baka kasi G6PD deficient and it will cause hemolysis, no? There are also other things like naphthalene balls. Do you still remember naphthalene balls? Our lolos and lolas used to put them in the cabinet, no? Para walang insects. So, but unfortunately, this would also cause acute hemolytic anemia in G6PD patients. Okay, so be very careful. Even henna. So advise your patients against it if they plan to having henna tattoo because it can cause hemolysis. All right. Some herbs are also associated with acute hemolytic anemia. So these are all also to be avoided by the G6PD deficient patients. Okay. So here's the naphthalene ball. Okay. But not all drugs are contraindicated. No? There's also a list of the drugs that are safe to take, no, that is safe to prescribe to G6PD deficient patients, but take note that they have to be given and taken in therapeutic doses. Okay, it has to be in therapeutic doses. All right. So there are antibiotics that we can give patients. Okay. And even paracetamol would be okay, basta as long as it is in therapeutic dose. Okay, so how do we screen patients and what do we order? No, if we're given, remember the case before, so what do we order? Laboratory workups that we can do. Okay. So of course, if it's a newborn, then of course you encourage the parents to have newborn screening for their baby. Actually, it's a law already. So there's a high compliance rate, no, with regards to newborn screening. But of course, meron pa ring lumulusot eh. But this should be a part of our advocacy also, no? So let us introduce the newborn screening test and encourage parents to have their kids tested, no? Because this really saves lives. Okay. And for cases, if you are faced with a clinical scenario that just like the one I presented, no, you can request for CBC, and usually the CBC would show anemia. The WBC you'll see are moderately elevated, and usually it would be neutrophil or granulocyte predominant. Okay, the platelet may be normal, increased, or decreased. And if you order reticulocyte count, then most likely it will be increased. Okay, and if you take a look at the peripheral blood smear, you'll see that this is normocytic, normochromic, but especially among patients who have no previous blood disorders, no? So they would have normocytic and normochromic features. And you will note marked anisocytosis and marked poikilocytosis. So anisocytosis, you'll see different sizes of the red blood cells, and poikilocytosis would be different shapes, no? You'll be able to observe that. And if you look further in the microscope, you will see that there are red blood cells that would have bite cells, and they would look like this. Okay. Okay. And if you request for a reticulocyte stain, you will see also Heinz bodies, as exemplified here in this picture. But this is a transient finding, so it would be very good if you will be able to catch that time, no, when they still the patient would still manifest Heinz bodies on their red blood cells. Okay. So check bilirubin levels, they are elevated. Liver enzymes would be normal. BUN would be transiently elevated. And you can request other labs as indicated, no? Wala naman pong dekahon na laboratory tests for these patients, eh. But you can order as needed, no? Depending on the assessment of your assessment on the patient. Okay, so for the case that I was presenting earlier, no? So it quite jives with the description that I mentioned in the previous slides, no? This patient came in anemic, the hemoglobin was as low as 80. There is a segmental predominance. The bilirubin levels were elevated. The urinalysis showed RBCs and yeast cells. And I ordered also because there's a progression of the cough. So the patient on X-ray had pneumonia. We checked for the urine CS, it's positive. The blood CS is negative. The electrolytes was also deranged, so we had to correct that as well. Okay, So what is the clinical course of these patients, no, with acute hemolytic crisis? Okay. So majority of them, even if severe, no, even if they have a severe hemolytic anemia or hemolytic crisis, it is self-limited, okay? And they would resolve spontaneously. Okay, and the hemoglobin levels would return to normal in 3 to 6 weeks, but it also depends, no? It depends on the dose of the offending agent that the patient intake in cases wherein the patient was given a particular medicine or food, no? It depends on the dose, on how fast your hemoglobin levels would go back to normal. It would depend also on if there's any concomitant pathology, and of course, the previous hemoglobin level. Okay, so renal failure is a complication of acute hemolytic crisis in G6PD patients, but it is a very rare complication. So how do we manage patients suspected to have acute hemolytic crisis? You may find this funny or too simple, but I would like to share it with you. I hope you still remember the dear old Richmond. So we learned this in med school and also in residency training, but I still use it today because it helps me, be organized in thinking of the management of my patient, and so that I will not miss anything. No? So what's Richmond again? Let's take a look. And I hope you'll find this helpful for you. No? F stands for fluids. So we're going back to the patient that I presented. Of course, although acute renal failure is rare complications, I don't want my patient to have that. No? So I made sure in managing that patient that the patient is properly hydrated. So check the urine output and make sure that the fluids you're giving are enough. So check the INO, the input and the input, and I would rather have it in the positive balance than a negative one so that my patient will not be dehydrated. Now, included in the fluids would also be managing the blood. No? So our patient came in with hemoglobin of 80. Now, as you will see later, it could be still tolerable because it's still within the physiologic limit. No? But then again, giving blood to your patient depends on the clinical situation at the moment. So my patient had pallor already, is in respiratory distress, given that he also had pneumonia, and so I decided to transfuse. And also, part of the management of the fluids will be nutrition. No? So the patient came in very irritable, doesn't want to eat, but I made sure that we should make sure that we should give proper nutrition to these patients because we want them to get better faster. Okay. So next is R. So what is R? It's respiratory. So I will refer always to the patient that I presented earlier. So respiratory. So it depends again. So does your patient have any respiratory symptoms or problem at the time of consult? In my case, that patient had pneumonia, so I had to treat that one also. And that actually might be the triggering factor why my patient had an acute hemolytic crisis. All right, so we gave antibiotics for the pneumonia. And surprisingly enough, once the patient was given antibiotics, was loaded with antibiotics, the clinical picture slowly but surely improved. So what's I? It's infectious. So assess the patient. Does the patient have any infection? Mine had, So may pneumonia siya and also UTI. Actually, the urine CS is also positive, so it's urosepsis, so that was treated as well. All right. So again, as I have shown earlier, it is the infections that is the most common trigger for this G6PD deficient patients to have a hemolytic crisis, acute hemolytic crisis. Okay, cardiac. So my patient had no cardiac condition, but when he came in, he was tachycardic, which could be due to the fever or the anemia. No? So when we transfused and when we gave proper fluids and antibiotics for the problem, the tachycardia also improved, no? And the heart rate returned to normal. Hematologic, of course, referred to us because of the hemolytic crisis or the hemolytic anemia. So again, a part of the hematologic would be the blood transfusion that we gave. Metabolic. So for this patient, the patient had deranged electrolytes as well. So we had to correct it. No, and also G6PD is a metabolic as well. So part of it is the G6PD deficiency. Oncologic, neurologic, and developmental. So far in that patient that I presented, no, I had no problem with that. So here you go. That's the Frichmont. I hope you will find it helpful, no, for you to be organized in thinking on how to manage, go about managing your patients, no. All right. So, but the most common question that we get and the most common referral that we get regarding these patients would be, do we need to transfuse blood? Sometimes this is the reason for the referral. No? They cannot really decide if the patient would be needing blood transfusion at that moment in time. No? So do we really need to transfuse blood? Okay. So as I have mentioned earlier, chronic anemia of gradual onset is generally well tolerated until the hemoglobin levels decline to very low levels of less than 8 grams per deciliter. If you look through some articles nor journals, some would say that we can still tolerate up to 7 grams per deciliter. But then again, there is no hard and fast rules on when to transfuse your patient. No, it depends on the situation and the condition of your patient. So we could have a patient that has hemoglobin of 80 but appears well, no, not toxic, not in distress. So you can hold off on transfusion and that would be fine, no, if you opted to just monitor the patient. Okay, but you can have a patient as well that has hemoglobin of 9 but would be in respiratory distress, severe pallor, no? So at that time, maybe a transfusion would be warranted. So there is, again, no hard and fast rules. Again, it would depend on your assessment of your patient. Okay, but here are some of the guidelines that we can use, no, to help us decide whether to give transfusion in patients who have acute hemolytic anemia among patients with G6PD deficiency. The first one is if the hemoglobin level is less than 7 grams per deciliter, then therefore the child should undergo a transfusion immediately. Okay, because below 7, it's not, there is a compensatory mechanism that happens already, no? So our body is not able to tolerate it anymore. So we have to transfuse. And second, if the hemoglobin level is less than 9 grams per deciliter, and there is an evidence that indicates a persistent brisk hemolysis, as manifested by hemoglobinuria, then immediate blood transfusion is also recommended. Okay. And the third one is that if the hemoglobin level is greater than 9, but hemoglobinuria persists, or if the hemoglobin level is between 7 and 9 grams per deciliter, but the child has no hemoglobinuria, then the child should be kept under close observation for at least 48 hours and should undergo transfusion if either the condition number 1 or number 2 develops. Again, so there is no hard and fast rules on when to give your blood. So as we have been often told, treat the patient, not the labs. Okay, so you can always tailor your treatment according to your patient's needs. Okay. So what do we advise the parents of patients who have G6PD deficiency? The first and foremost is prevention, okay? So you should avoid inciting agents or conditions that would lead to hemolysis. Okay, so there is again, so all G6PD patients are being given a kit or a list of all the things that are prohibited, not things that should not be taken. So they should have it at all times, okay? And of course, we should advocate proper immunization and on-time immunization for these kids because, again, infection is the number one trigger, no, for acute hemolytic crisis among these G6PD deficient patients. So keeping them healthy will also prevent, no, having that problem, okay? And of course, we can always refer them for genetic counseling, no? So for future pregnancies, they will be very much be aware of the probability of the next child having a next child having G6PD deficiency as well. Okay. So parents would also ask, no? What's the prognosis? Lalaki bang matalino yung anak ko? Lalaki ba siya? Tatanda ba siya? The prognosis is good, okay? And G6PD deficiency is compatible with long life, okay? As long as you prevent them from taking in those that are prohibited, no? That would cause problems, okay? So avoidance of agents or conditions that will result to complications is very important. But otherwise, G6PD deficiency would have a good prognosis. And yes, they can live a normal life and grow up to be like this, no? They can be our future doctors also, okay? So with this, thank you for your attention. I hope you learned something from today's session. Thank you.
Thank you, Dr. Domeline Arca, for that really interesting and informative lecture on G6PD deficiency. Now, to go on to our next topic, we all know with the inclusion of hemoglobinopathies in the extended newborn screening, we are seeing more thalassemia among our pediatric population. Our second speaker, Dr. Edwin Rodriguez, will tackle the emerging nutritional challenges in children with thalassemia. Dr. Edwin Rodriguez is a graduate of the University of Santo Tomas, Faculty of Medicine and Surgery. He took his residency at Cardinal Santos Medical Center and his fellowship in Pediatric Hematology and Oncology at UST. He also took his master's in health profession education at UST with honors, magna cum laude. At present, he's a fellow of the Philippine Pediatric Society, Philippine Society of Pediatric Hematologists, Philippine Society of Hematology and Blood Transfusion, Philippine Society of Experimental and Clinical Pharmacology, and an outstanding member of various organizations which he is passionate about, his advocacies like blood transfusion, hemophilia, thalassemia, to name a few. Without further ado, let us all welcome Dr. Edwin Rodriguez, lecturer extraordinaire and a dear friend.
Good afternoon. I'm Dr. Edwin Rodriguez, a pediatrician and pediatric hematologist. And for this afternoon, we'll be talking about revisiting nutritional challenges in children with thalassemia. Our objectives for this afternoon will be to discuss common nutritional concerns in children with thalassemia and enumerate concrete steps to improve the nutritional status of children afflicted with thalassemia. Thalassemia is a genetic disease in which oxygen is not properly supplied to body organs due to abnormalities in the hemoglobin structure. It has a high prevalence in the Mediterranean as well as tropical regions like Asia and Africa. The annual incidence is 1 per 100,000 population worldwide. Repeated blood transfusions and increased iron absorption in the GI tract may cause iron overload, as absorption in the intestines happen 3 to 4 times that of a normal child. Thalassemia affects the following organs: liver, heart, pancreas, glands like the thyroid and pituitary, as well as other endocrine organs. The mechanism of iron overload in thalassemia involves chronic hemolysis, repeated blood transfusions, and increased iron absorption in the GI tract. In the long run, iron overload can lead to high levels of free radicals, producing high oxidative stress in tissues, as low and depleting antioxidants, producing or causing them to be present at low levels. There are some nutritional red flags in thalassemia which we can use in our management and engagement with this group of patients. Growth failure can happen in 25 to 75% of them, depending on the thalassemia syndrome and the disease severity. Growth failure can be multifactorial in origin. Chronic anemia, chelation toxicity, and iron-associated endocrinopathies can contribute to this phenomenon. Pubertal delay is also another nutritional red flag in thalassemia, as patients may score with consistently low height recordings in their growth charts. And growth failure is related to most nutritional deficiencies seen in thalassemia. What are the causes of reduced growth rates in thalassemia? 1, the increased caloric expenditure due to a hyperactive bone marrow, decreased protein turnover, and increased cardiac output as a result of chronic anemia. Hemoglobin concentration in these children was negatively associated with energy expenditure. Another cause of reduced growth rates in thalassemia will be the increased requirements for specific nutrients. We have to remember that folate is readily catabolized by ferritin, and in the presence of hyperactive erythropoiesis confounded by iron overload, there is inevitable folate deficiency. Increased oxidative stress can also reduce growth rates, as insufficient antioxidants associated with oxidative stress is produced. And increased essential trace element perturbation or disturbance due to iron overload can also contribute to reduced growth rates, as low zinc and copper levels ensue as a result of high metallothionein levels, causing trace element sequestration. Now, some fat-soluble, water-soluble vitamins like vitamin A, vitamin C, vitamin D, and selenium are decreased in patients with thalassemia. However, there are some trace elements, minerals, and vitamins which remain unchanged, like copper, vitamin B12, gamma tocopherol, and vitamin E. We have to remember that circulating levels of many nutrients tend to decrease with increasing age. Now let's take a look at some more specific vitamins associated with nutrition in thalassemia. Vitamin D, which is basically to support clean skeletal and extraskeletal functions in the body, is a vitamin synthesized by the human body. 80% is produced in the skin, and the levels of vitamin D in the body is affected by geographic latitude, season, altitude, cloud cover, air quality, time of day, clothing, skin pigmentation, and the use of sunscreen. Vitamin D has unique hormonal functions for bone health, reduction of bone fractures, cardiovascular health, immune function, blood pressure regulation, and cancer prevention. There were several studies cited by the publication of Dr. Fung, and this involves a consistent relationship between vitamin D and cardiovascular health, not observed. Thalassemics have a greater risk for vitamin D deficiency and have a greater response for supplementation. Hence, vitamin D monitoring is important for children with thalassemia. Likewise, there was a weak correlation between vitamin D and left ventricular ejection fracture. Weak correlation between vitamin D and left ventricular ejection fraction. The parathyroid hormone was higher in beta thalassemia major patients with high myocardial iron. Reduced levels of vitamin D also pose a 10-fold greater risk of lower bone mass. So indeed, vitamin D is a nutrient that must be carefully monitored in patients or in children with thalassemia. How about zinc? Zinc has been associated with growth, immune function, and bone health. We know that zinc is essential for cell division, cell differentiation, and gene expression. As I've mentioned, it serves a function for the immune system, bone health, vitamin A metabolism, thyroid, insulin, testosterone, and growth hormone functions. Deficiency of zinc, is largely associated with its strong similarity to the size and charge of iron. This similarity to iron gives it a high potential for chelatability when iron chelation treatment is started. Zinc deficiency is associated with 80% or in 80% of adolescents with beta thalassemia. Additional contributory factors to zinc deficiency include proximal renal tubular damage, hyperzincuria, and abnormalities in zinc metabolism. Studies have shown that there is a relationship between diabetes and zinc deficiency among thalassemics, and that zinc deficiency might lead to an exacerbation of the inability of the pancreas to secrete sufficient amounts of insulin in response to glucose stimulation among transfusion-dependent thalassemics. How about iron? Diet low in iron, such as red meat, organ meat, and fortified breakfast cereals, is recommended for all patients. We have to remember that, or rather, iron impact RBC transfusion of 200 milligrams is equivalent to 20 milligrams per day. And that is if the transfusion is given 2 units every 3 weeks, versus the iron from an iron-rich diet, which is only 4 milligrams, assuming that the intestines have an efficient 90% absorption. Iron deficiency happens when we reduce iron in the diet. And this is an important nutritional counseling material, as these patients have a tendency to overabsorb iron from the GI tract. Here are some of the vitamins and minerals which we must closely monitor among patients with thalassemia. And provided in the middle part of the table are the functions associated with the vitamins and minerals and the required or recommended dietary or daily doses for these vitamins and minerals. Now, there are several diet implications in children with thalassemia. Dairy food groups that contain calcium, high fiber, food groups with phytate, coffee and tea due to the phenolic compounds, and even curcumin are highly absorbed from the GI tract and enhances iron absorption with it. Now, addition of food groups with iron chelating activity plus a low iron diet may improve the prognosis and prevent complications of iron overload. Likewise, the application of a comprehensive educational program could improve serum ferritin levels and eventually decrease complications of iron overload in thalassemic patients. We have to remember that serum iron fluctuates daily and is influenced by diet and infectious or inflammatory diseases. Here are some food groups to avoid in children with thalassemia. We should advise avoiding egg yolk, jam, dried fruits like dates, tomatoes, peppers, broccoli, red meat and liver, dark chocolate, and green leaves. While diet appropriate for children with thalassemia includes egg white, honey, milk products, bran bread, cereals and wheat, chicken breasts, fish, milk, coffee, tea, and vegetables like cabbage, carrots, and onions. Now, in a study conducted by Dr. Elmonane, they tried to study the impact of dietary modification on serum ferritin. And this particular study measured serum ferritin before the intervention on diet and measured it again after 6 months. So based on the results of this study, the role of diet as an adjuvant therapy for drug chelation in thalassemia patients was observed. Dietary modification for 6 months caused a significant decrease in serum ferritin levels, and many food groups can interfere with iron absorption from the gut and therefore decrease serum ferritin. So among patients with high compliance to the dietary modification intervention employed in this study, a concomitant decrease in serum ferritin was observed 6 months after the intervention. Another study also tried to look at the impact of dietary modification on mean iron indices. And again, this now employed dietary modification and measured the serum ferritin level before and 2 months after, comparing a control group and an intervention group. And as we can see, the p-value was statistically significant in the intervention group, where serum ferritin levels decreased 2 months after intervention compared to the control group, where there was no significant impact on serum ferritin levels. Similarly, when they tried to compare the control and the intervention group and the difference between the groups, again, serum ferritin was also significantly decreased in the patient with intervention, producing lower levels of serum ferritin with a significant p-value. Now let's try to look at dietary do's and don'ts. Examples will be limitations in meat consumption. We have to emphasize that heme iron-rich food include meat, fish, and some parts of poultry. Liver and kidneys are also rich in heme iron. So it is better to limit consumption of these food groups and to recommend instead vegetable proteins and white instead of red meat. Non-heme iron-rich food includes eggs, chocolate, cereals, vegetables, fruits, roots, and tubers. Absorption rate is much lower. Only 3 to 8% of iron in this food group is absorbed by the body. The absorption of non-heme iron is influenced by consuming other food groups. Serving non-heme iron-rich food might increase or decrease the absorption of iron. How about dairy? Milk, cheese, and yogurt reduce the absorption of iron. Calcium is necessary to prevent osteoporosis. Cheese, milk, cheese, or yogurt in the diet may also be good for thalassemia patients. Wheat, corn, oats, rice, and pulses such as soya beans, lentils, and peas reduce the absorption of non-heme iron. So this is also recommended as part of a thalassemic child's daily diet. Vitamin C is a factor that increases iron absorption. So this is found in citrus fruits, tomatoes, and certain vegetables. It is better to avoid eating fruits and vegetables with high vitamin C or immediately after a meal. However, because fruits and vegetables contain a variety of vitamins and antioxidants and must be consumed it is better to eat them between 2 meals or eat them as a snack. Vitamin E. Vitamin E can combat against oxidative tissue or cellular stress. And this is due to its effect on reducing cell damage. Vitamin E containing substances are therefore recommended. Food groups rich in vitamin E include fruits and other sources, including plant materials, animal fat, vegetable oils, peanuts, fresh nuts, cabbage, soybeans, and wheat germ oil. Now, there are some food supplement, most of them herbal in source, that can be given or included in the diet of a thalasssemic child. L-carnitine is an antioxidant with cardioprotective properties essential for the metabolism of long-chain fatty acids. The recommended dose is 50 milligrams per kilogram per day, and benefits include improvement in diastolic function and exercise, performance improvement in pulmonary artery systolic pressure in patients with pulmonary hypertension, and an increase in transfusion intervals. However, L-carnitine must not be overused because toxicity can lead to seizures and even hypothyroidism. Silymarin has antioxidant properties and is invoked for its hepatoprotective property. It is given at a dose of 140 milligrams 3 times a day. Wheatgrass contains chlorophyll, vitamins, and enzymes, and may be beneficial to increase red cell production and widen intervals during or in between transfusion. Alcohol, smoking, and drugs of abuse are, of course, all should be avoided in patients with thalassemia. Now, exercise also has an important impact in children with thalassemia. Exercise produces the following benefits. It increases the percentage of iron autolyzed in tissues. It changes the RBC membrane release of tissue iron, causing high serum ferritin and serum iron. It increases hemolysis of unfavorable thalassemic hemoglobin to lower serum ferritin and decreases absorption in iron or of iron from the GI tract. Exercise in thalassemia patients, doing some exercises based on one's tolerance, reduces the bad effects of iron in the heart and improves cardiovascular function. Regular exercise reduces iron overload in patients with thalassemia by decreasing iron absorption from the gut. Walking for at least 30 minutes on most days of the week and preferably all days of the week is advised. Then you can increase the time based on tolerance and also enhance speed gradually. So in terms of recommendations for exercise, it is advised to gradually allow your body to get used to the exercise. Start with easy exercises that increase intensity and duration slowly. Do gentle, soft, and warming exercises. Do not stop exercising suddenly. Decreasing exercise gradually is advisable before completely stopping. Avoid exercises in very cold, hot, or humid weather conditions, and to wear light and bright clothes. Avoiding tight clothes to allow heat loss is also recommended. Likewise, the use of hats and sunscreens when doing exercise under direct sunlight is recommended. Drinking cold water before and after exercise for hydration, and being familiar with signs of heart disease should be a must, and the thalassemic child or adolescent should know when to stop. Now, preventing infections in thalassemia is also a must because we are aware of the association of bacterial infection and iron chelation. So some common steps or measures for children with thalassemia to avoid infection or prevent infections include the following: washing fruits and vegetables before eating them, hand hygiene and washing hands, vaccination, travel vaccination and health point checks, avoid swimming in rivers, lakes, and public pools, boiling water fully before drinking, activity rest balance, early detection and reporting of infections, and avoiding contact with potentially infectious individuals. So here are some nutrition monitoring recommendations that we can apply to our patients. For height and weight, we should do monthly monitoring. For sitting height, every 3 months. For puberty and serum vitamin D, every 6 months. And the rest of the blood chemistry levels, including albumin, folate, vitamin C, vitamin E, tocopherol, zinc, copper, selenium, and ceruloplasmin, ideally should be done annually. Growth velocity and bone densitometry are also recommended to be conducted annually. Nutritional guidelines include annual medical examination, periodic nutritional counseling and rehabilitation if needed, annual monitoring of certain important blood chemistries, vitamin D levels, ideally every 6 months, multivitamins without iron, and folate supplementation of at least 1 milligram per day. Areas of future research in this particular aspect of thalassemia in children includes trying to look for non-invasive, potentially anabolic nutritional interventions to improve bone density, especially when they become adults. Thoughtful investigation of the effect of oral chelation therapy on trace element status, including static as well as functional markers and biomarkers of oxidative stress. Exploration into the role of vitamin D deficiency and risk-benefit supplementation with vitamin D, not only in bone health, but also to improve immune function and prevent cardiac disease. Collaborative multi-center site studies to explore relationships between circulating levels of nutrients and various comorbidities, and randomized controlled trials to test the efficacy of individual nutritional therapies towards the improvement of growth, pubertal development, immune function, oxidative damage, and bone health. In summary, iron overload associated with thalassemia has a measurable impact in the nutritional status of children with thalassemia. Nutritional red flags among thalassemics involve growth retardation and pubertal delay. Nutritional intake, requirements, and expenditures among thalassemics must be monitored. Diet and exercise have significant positive impact on serum ferritin levels, and nutritional guidelines and monitoring strategies must be incorporated in routine thalassemia care in children. Thank you very much for your kind attention.
Thank you, Dr. Edwin Rodriguez, for lecture. Challenges. Nutritional challenges and deficiencies, as well as the impact of dietary manipulations and additions of certain vitamins and minerals to help our thalassemic children cope with growth and development. Likewise, Dr. Domelin Arca, thank you for that interesting and informative discussion on G6PD deficiency. Now we will entertain questions, and I will start off with Dr. Arca. Doctora, you mentioned that a lot of G6PD deficient children are not toxic. So are we supposed to refer all our G6PD deficient babies, or when are we supposed to refer them to a pediatric hematologist?
Okay, thank you, ma'am. So I see nothing wrong in referring them to our friendly hematologist. So of course we can always help the attending physician or the primary physician advise the patient on what to expect or what food or drugs to avoid, and the things that we have to advocate to keep these kids healthy and free from hemolysis. So I don't think that there's anything wrong if we refer them to subspecialists. So of course, we are always willing to help out. But, ma'am, since they attended our lecture today, our webinar today, I think they will be able to advise the parents well now.
Thank you, Dr. Arca. I agree with you. Maybe for an initial consultation, and we can add more. We can allay more the concerns of parents. Well, the second question will be sort of a repetition from what you said. What will be your recommendations? What are you supposed to watch out for this will refer to older children with G6PD deficiency.
Okay, so for older children, so okay, so they are diagnosed with G6PD. Okay, so in any journal, ma'am, that I check, no, lahat sila, what they would say is avoidance of those inciting factors. That's the number one key. Prevention of intake of those that will lead to complications. So prevention is the key, I guess. So that would be the best advice I could give them. And then also, let's advocate for healthy lifestyle for these kids, no? So number one, siguro, we could advise good nutrition for them so that they will have healthy growth, they will be healthy. And also, let's advise them on their vaccinations. I think it's very important kasi lalo na ngayon in this time, no? So takot din silang pumunta sa clinic and all, no? But we should remind them that their kids should have the scheduled vaccination, because I think that would prevent infections, and we know that infection is the number one cause, no? For us, no, sa atin sa Philippines, it's the infections and the intake of the drugs, no, that causes the hemolysis in these kids. So making them aware of it, I think, would help a lot. Okay, so for those older kids who are not diagnosed with G6PD deficiency, it's either no newborn screening was done before, or that they had a newborn screening done but they could not recall the results, and you are highly considering a G6PD deficiency in this patient, and based on the signs and symptoms that he presented with, it really jives with G6PD, there is a test that can be done, no, to verify if this indeed is a G6PD deficiency. There's a gene test that can be done, so you have to refer the patient to a geneticist so they can schedule the test, and the test would be sent out abroad, no? But so it can still be done and the patient can still be diagnosed.
Thank you, Dr. Arca. I completely agree with you. Now, there are a couple of questions for Dr. Rodriguez also. And the first question is, since you mentioned some food supplement for thalassemia patients, do you recommend them as part of their regular diet?
Well, I think, Doctora, as the term states, so they are food supplement, and under that category, they remain to have no approved therapeutic claims. And I think another limitation is really the lack of clinical trials that will fully support the favorable effect or effects of these food supplements. But as most of them are from herbal sources, they are in most instances safe, and if used, no, as a supplement to improve the nutritional status of our patients with thalassemia, then probably they can be used. But to recommend them as part of their routine diet may still require additional evidence, no, before it becomes part of nutritional guidelines.
Okay, and there's another question for you, Dr. Rodriguez. Why is preventing infections important in the case of children with thalassemia?
Well, I think I will echo the answer of Dr. Domilin a while ago. I think the reason is probably very similar also to why we would like to prevent infections in G6PD, both being inherited hemolytic anemias, and we know that the predisposition of the red cells, to premature destruction is made worse by the presence of infections. And aside from that, as we have mentioned in the lecture, that infections in general tend to worsen the hemolytic condition of patients with inherited hemolytic anemias, and this will of course increase the degradation of hemoglobin and increase unwanted iron inside the body or even stored in the body. So I think it is a vicious cycle of infection worsening the iron overload and worsening the overall condition of children with thalassemia. So again, I agree with Dr. Domilin that vaccination should be emphasized. Nutrition and lifestyle for children with thalassemia should also be started very early on, and all efforts to keep them healthy should be done to prevent infections and its unwanted complications.
Okay, last question, Dr. Rodriguez. How can we minimize the negative impact of thalassemia in a child's nutritional status?
Well, as I've mentioned, giving them the right kind of diet, avoiding food groups that tend to increase or facilitate an increase in iron absorption, and taking in food groups that tend to limit iron absorption may also help. Again, a balance of nutrition and activity, physical activity, can help minimize the impact of nutritional deficiencies. Monitoring of certain important vitamins and trace elements, if available, or if not possible, supplementing them early on can also minimize the risk of deficiencies. And finally, regular consultations with the pediatric hematologist or their general pediatrician for advice, nutritional advice, and lifestyle advice can also help minimize the negative impact of nutritional problems in thalassemia patients.
Thank you, Dr. Rodriguez. That concludes this afternoon session on inherited hemolytic anemia among children. We thank both Dr. Rodriguez and Dr. Arca for such informative and interesting lectures on both topics. And we hope that you enjoyed our webinar today and that you learned a lot. And thank you again for tuning this afternoon.
Good day. Thank you again for joining our online scientific session in cooperation with the Philippine Society of Pediatric Hematology entitled Inherited Hemolytic Anemia in Children, Perspective and Practices with 3 PPS-CPD units. In behalf of the Board of Trustees of the Philippine Pediatric Society, we thank our 2 distinguished speakers for sharing their time and expertise. To Dr. Domilin Arca on the current perspective in G6PD deficiency among children. To Dr. Edwin Rodriguez on revisiting nutritional challenges in children with thalassemia. To our moderator, Dr. Minerva Ramos, who is also the president of the Philippine Society of Pediatric Hematology. To our council directors on continuing professional development. To our committee on scientific meeting, chaired by Dr. Christine Gutierrez. To our committee on CPD Online, chaired by Dr. Flerida Hernandez. To our Child Informatics Committee, chaired by Dr. Judith Fatima Garcia. To our Secretariat, Carl and June. Finally, to our Almighty God for the success of this activity. Hope to see you all again and hope you will join again on our next scientific session on October 31. Again, thank you very much and take care. God bless.